Good afternoon and welcome to today's presentation, The Changing Face of Liability in Obstetric Anesthesia. Before we begin our presentation today, I would like to take a few moments to go over some housekeeping items. We will be recording this webinar, and this webinar is CLE approved and will be asking that you enter a passcode for CLE credit a few times throughout the presentation. In today's webinar, Dr. Fogel will discuss Primer on Obstetric Anesthesia, American Society of Anesthesiologists Standards, ASA OB-Anesthesia Guidelines, ASA Closed Claims Report on Obstetric Anesthesia, Case Studies, Other Areas of Potential Liability, OB versus Anesthesiologist, Anesthesiologist versus CRNA, New Areas of Potential Liability, Crisis Management, and ongoing skills evaluations for the entire team. To give you a little background about our presenter, Dr. Stephen Fogel, he received his degree from the University of Missouri in 1976. He was an assistant clinical professor for the University of Missouri at Kansas City School of Medicine. Dr. Fogel was also an assistant professor at Washington University School of Medicine and St. Louis University School of Medicine. He was also an associate professor of anesthesiology and works part-time in the Department of Anesthesiology and Perioperative Medicine at the University of Missouri. For those of our attendees who require a code word for tracking purposes, the code word for today is SPACE. During the presentation, we will take short breaks, and during that time, we'll ask that you enter this code into the Q&A widget for CLE reporting purposes. The Q&A is located to the left of your screen. Please remember that if you're applying for CLE credit, you must log onto your computer as yourself. Also, please remember to complete the survey that will appear to the right of your screen at the end of the presentation. As a provider of CLE credits, we are required to have supportive information that you have attended, and in many states the survey is required. CLE certificates will be provided within 24 to 48 hours via email. CLE credit is only available to those who have attended the live presentation. You are not eligible to receive CLE credit if you view this presentation on demand. Also, the PowerPoint slides can be downloaded from the resource list on the left of your screen. Dr. Fogel welcomes your questions. Please use the Q&A widget to submit your questions throughout the presentation. We will take intermittent breaks so that Dr. Fogel can respond. Thank you all again for attending today, and Stephen, the presentation is now turned over to you.
Thank you very much, Amy. Just to go over the rationale of how I'm arranging this webinar, in order for you to understand the issues that we face on a regular basis and understand where the pitfalls occur and where things can go wrong, I think it would be best if you could bear with me so that I can give you a brief primer on anesthesiology. Hopefully some of you will find that interesting. I would then like to move on to a discussion of standards and guidelines as they apply to obstetric anesthesia particularly, although some of them will apply to anesthesia in general, and then review the latest data that has become available in the Anesthesia Closed Claims Report on obstetric anesthesia. With that background, then I'd like to move on to some case studies which I have been involved in and highlight the foregoing, and hopefully we'll have time that I could talk about other areas of liability and what may be coming down in the future. All right. Basically, there are two methods of administering anesthesia, general versus regional anesthesia. There are other types of anesthesia that might include degrees of sedation. I won't go into that. But with respect to general anesthesia, to give some definitions, the patient is rendered unconscious under these conditions, and usually by an induction agent. Most commonly, it's propofol. In addition to that, agents are administered to provide pain relief, and the reason for this is that just because the patient is unconscious doesn't mean that the body doesn't still react. The surgical stimulus will still get to the brain. And remember that the body doesn't know that it's a skilled surgeon's scalpel that's cutting into a body part, such as an abdomen. All the body knows is it's being attacked by a knife. In addition to that, the agents are administered to provide muscle relaxation, which temporarily paralyzes the muscles. And this is done often for surgical needs. Patients are as a result of this, patients are rendered unable to breathe spontaneously. This often occurs with the induction of anesthesia, and this is probably what the problem that Michael Jackson got into, is that the propofol that was administered to him caused him to stop breathing. When this occurs, then the anesthesiologist has to take complete control of the patient's respiratory functions. Regional anesthesia, in layman's term, is a part of the body that is rendered senseless or numb or frozen, other terms used by the lay public. And it is done by injecting a local anesthetic. Novocaine has been familiar in the lay public in the past. We don't use that very much anymore at all. But in these cases, the patient can be fully awake and conscious, or they can be sedated. As a result of that, the patient can breathe on his or her own. Another advantage to regional anesthesia is none of the surgical stimulus gets to the brain, and as a result, the body has no knowledge that that part of the body is being injured or attacked. All right. So when we give a general anesthetic, what we normally do, once the patient is asleep, we may need to put in an endotracheal tube or a breathing tube. Not always necessary, but usually it is. And the reason for this is that complete muscle relaxation might be required for the surgical procedure. Maybe a result of the position of the patient. For example, a patient could be having back surgery and on his or her stomach, and it would be difficult to manage the patient's breathing with a face mask. Another reason, and this has a great deal of applicability in obstetric anesthesia, is that there may be food in the stomach. An endotracheal tube has a balloon near the end of the tube that, when it's blown up, it seals the walls of the trachea or the windpipe, so that anything that comes up into the throat and runs down into the trachea doesn't get into the lungs. And when patients become unconscious, they are not able to cough up anything that gets into the trachea like we normally would, and it would just run down into the lungs and could potentially cause a great deal of damage. When an induction agent is given, the patient usually becomes apneic, meaning stops breathing, just from the induction agent alone. And then, as a result of that, the patient is given breath by the anesthesiologist with a face mask so the patient continues to breathe. If the breathing with the mask is successful, then we give a muscle relaxant. And for the usual muscle relaxants we take that we want to last for the duration of the surgery, this can take a while for the muscle relaxant to take effect. So we don't yet intubate the patient because we need the muscle relaxation to facilitate that. And it can take several minutes, and once the muscle relaxant is taking complete effect, then the patient is intubated. If, however, we cannot breathe the patient with a mask, then we have to do something else. And if the surgery is not emergent, we usually allow the patient to awaken. If it is emergency surgery, then something else has to be done in order to maintain the patient's breathing. Now, there's a technique called a rapid sequence induction, and we do this when we believe that a patient has a full stomach or any other, meaning food in the stomach, or any other risk of aspiration. When we do this, we try to limit the amount of time that aspiration can occur. And so what we do is we give an induction agent and then a rapidly onset, short-acting muscle relaxant in rapid sequence, one after the other. So hence the term rapid sequence induction. We don't take any time to assure that the anesthesiologist can breathe for the patient before the muscle relaxant is given, because we don't want any air to get into the stomach and increase the risk of regurgitation. The endotracheal tube is then placed as soon as the muscle relaxant takes effect, and for the muscle relaxant we use for these situations, it takes about a minute. Now, in order to let you know or understand the processes that we need in getting a patient intubated and why it may become difficult in some patients, I think it'd be a good idea to show you what's necessary. I don't have a pointer, so hopefully you'll be able to follow with me anyway. If you notice, when the patient's head is in a neutral position while lying flat, you can see that the line of sight must go around a corner. in order to see the opening of the trachea or the breathing tube, and this is known as the glottis, and the glottis is the space between the vocal cords. So the patient's head must be extended backwards. The tongue has to be moved out of the way. We do this with an instrument called a laryngoscope. And as you can see, in some cases, this may be difficult or impossible based on how the patient's airway is built, such as a receding chin, a large tongue, trauma to the airway, or just generalized swelling in the face and throat. Now, pregnant patients in the second and third trimester are considered to be at risk of aspiration, and performing a rapid sequence induction when we're administering general anesthesia is considered the standard of care. The reason for this is that as the uterus grows, it pushes the stomach up towards the chest, and the sphincter that creates a barrier between the stomach and the esophagus or food tube tends to weaken. And so even if there's a small amount of food or acid in the stomach, it can't come up. It's not uncommon for some women at the end of pregnancy to complain of constant heartburn. The downside to rapid sequence induction is that we don't know if the patient can be ventilated or intubated until the muscle relaxant has already given. So whenever we're faced with this, there's always a little bit of nervousness about the situation, although we do have ways of getting around it if we have to. All right. When we do get into difficulty with an airway, we have basically two categories that define the kind of trouble we can have. One is a difficult airway, and that's an airway where we cannot ventilate, breathe for the patient, nor can we intubate the patient. And as you can understand, that would create a great deal of concern on everybody's part. If it's a difficult intubation, then we are able to breathe for the patient, but we can't get the patient intubated. And this gives us a little bit more room of our margin of safety. Now, to deal with these situations, the American Society of Anesthesiologists, or ASA, has developed over the last, I'd say, 2 decades or maybe a little more, an algorithm that gives guidance to dealing with the difficult airway or difficult intubation. It's a systematic approach to this problem in difficult situations. It addresses a broad range of patient conditions and situations, and it is pretty generally considered to be the standard of care. And everyone who administers anesthesia or takes responsibility for an anesthetic should be fully familiar with this algorithm. There's also a separate algorithm that applies to the obstetric patient, and it takes into consideration whether or not the fetus or baby is in trouble or not. Now, a little bit of anatomy, so that I can explain regional anesthesia better. This is a cross-section of the lower back. And if you see the dark circle in the middle with little dots in it, it represents the spinal sac. The spinal cord ends about 2/3 down the way of the back. This is below that. This is where we normally go for a spinal anesthetic. And what you see here are just the spinal fluid, which is represented by the dark color, and the spinal nerves that hang off the spinal cord before they exit the bony spinal canal, that are represented by these little dots. All right. Many people don't understand, lay people don't understand the difference between a spinal and an epidural, but I think it's very important for this webinar that you understand that. A local anesthetic for a spinal anesthetic, a local anesthetic is injected into the spinal sac. We give a single injection normally. It's difficult to control the level of the block. You have to have an idea of just how much to give based on patient conditions. And we usually require a very, very small amount of local anesthetic, a small dose, in order to achieve the desired effects. For obstetric anesthesia, say for a cesarean delivery, there is no measurable drug transfer from the mother to the baby when we use the spinal. An epidural anesthetic is an anesthetic that is administered in the space around the spinal sac. Usually we insert a catheter. In obstetric anesthesia, this is very, very commonly used for labor pain management, which, by the way, is pain relief and not a surgical level of anesthesia. I'll get to that in a minute. And we can not only continue to infuse medication as necessary, but we can better control the level of the block. One of the things that's very important to realize, however, is that this is a very large space, and we have to use large volumes and large doses of local anesthetic to achieve the desired effect. This will become important later. All right, so where can things go wrong with epidural anesthesia or analgesia? When we place the catheter, you might be able to notice here, hopefully, that the catheter can go in two places. They show here more, but the two places we're worried about is either in a vein, where a patient gets all of the dose of local anesthetic that does not get in the epidural space but is delivered systemically. These large doses, as a result, can cause toxic reactions and even death. Another area where it can go is if the catheter goes into the spinal sac and the anesthesiologist doesn't know that, giving the large doses of local anesthetic intended for an epidural will be very, very much an excess dose for a spinal anesthetic. The local anesthetic can travel all the way up to the brain. This can happen very quickly. The patient will lose blood pressure very quickly. The patient will stop breathing quickly, and there's likely to be an associated cardiac arrest as well. Now, with general anesthesia in the pregnant patient, this is, for the reasons I'll discuss, there's a higher risk in the pregnant patient than there is in the non-pregnant patient. One thing is airway edema. Women will often complain of swelling, and you'll notice it as women progress in their pregnancy, but it's not only in their legs, it can also involve their mouth and throat. There's a decrease in functional residual capacity, and what this is the volume of air that is left in the lung after someone ends a normal breath, and this could be referred to as oxygen storage in the lung. Complicating and the reason for this is that the uterus is pushing up in the abdomen, and that pushes everything up into the chest, and that takes up some of the space. Not only that, but there's an increased consumption of the oxygen that is in storage. Remember, the mother's breathing not for herself, but also for her baby. There is a decrease in lower esophageal sphincter tone. I discussed that later, that the sphincter becomes weak between the stomach and the food tube, and so anything in it can rise up into as high as the throat. When women go into labor, their stomach basically stops. The stomach doesn't empty, and even if a woman hasn't had anything to eat for many, many hours, that food is still there. Weight gain and enlargement of the breast can cause some logistical and physical barriers to getting a patient intubated. Just to familiarize yourself with the obstetric anesthesia records, so if you come across these, it won't be foreign to you. And so I'd like to point out what it contains. This happens to be a handwritten record, and there are institutions that are moving more and more to electronic records, but they all contain the same thing. At the top, as you can see, is a space for the diagnosis and the surgical procedure being performed. At the right top is information regarding the anesthesia technique and airway management. Lower down is a list of the gases and medications that are given, and there's space for documenting the dosage and the timing of administration. Lower down further are spaces for monitoring methods, and this includes EKG, the type of breathing control, the amount of gases and breathing that is in the lungs and what comes out. The grid further down is where we record vital signs, and there's usually space elsewhere in the record for added notes. On the back side of the record is a summary of the history and physical examination that the anesthesiologist performs, any pertinent laboratory results, and at least the initial anesthetic plans. All right, now with this background, I'd like to move on to the ASA standards, and primarily as they relate to obstetric anesthesia. Standard 1 basically says that whoever is administering the anesthetic has to be in the room with the patient the whole time. Standard 2 is detailed. I'll try to go through them quickly without running it through them too fast. But basically, 1 is that the patient's physiologic parameters have to be measured at all times. If an anesthesia machine is being used and we're giving ether-like gases, which we don't use ether anymore, then the concentration of those gases have to be measured. If a patient is receiving general anesthesia, then we have to monitor for the presence of carbon dioxide in the exhaled gases. The reason for this is that carbon dioxide comes only from the lungs, although there's a little bit in the stomach. So if a breathing tube is in the stomach, then initially you'll see some low levels of carbon dioxide, but they'll go away very quickly. If we're going to intubate a patient, then we have to have I have to have a measure of the exhaled carbon dioxide, because again, it tells us that the endotracheal tube is in the right place. This is extremely important, and it's been a boon to anesthesia safety over the last 20 or 30 years. All right. At a time in which all anesthetics are given, we have to monitor the oxygen level in the patient's blood. And any of you who have had any kind of procedure, including sedation, you may have had a little clip on your finger placed that has a little light in it, and that's measuring the oxygen level in your blood. If we are using machine to breathe for the patient, then we have to have a monitor that tells us that the machine is disconnected with the patient. Usually these are very loud, annoying sounds, and the whole room knows that that there may be a problem. If regional anesthetic is given or used as a major technique, then we have to monitor the patient's respiratory functions clinically. I have this in red because this is a new requirement, a new standard. Now, I don't think everybody is doing this yet, but if we are giving moderate or deep sedation, then we have to have a way of detecting that expired carbon dioxide is present. An EKG has to be taken or continually displayed on the anesthesia monitor, and every patient receiving any kind of anesthetic has to have their blood pressure measured and pulse rate measured every 5 minutes or more frequently than that, depending on the patient's condition, the operative procedure, and the like. Every patient who has a general anesthetic has to have a way of monitoring the circulatory function. We almost always use the pulse oximeter. Pulse oximeters today will have I believe a tracing of the pulse trace on the monitor, and we use that to monitor circulation. And patients in whom we expect or intend to have a significant change in the temperature has to have the temperature monitored. Now moving on to ASA guidelines specifically for obstetric anesthesia. Neonatal anesthesia refers to either epidural or spinal anesthesia. And oftentimes it is not only administered in an operating room. Obviously it's given in patients' rooms when they are in labor. And when we are doing that, we have to have the necessary equipment and drugs to manage a resuscitation. Guideline 2 says that the anesthesia should be initiated by a physician with appropriate privileges. That means an anesthesiologist, essentially, or under the direction of an anesthesiologist. For laboring patients, an epidural should not be administered until the patient has been examined by a qualified individual. I'm going to read this very carefully. It's in red because not everybody is doing this. A physician with obstetrical privileges to perform operative vaginal or cesarean delivery who has knowledge of the maternal and fetal status and the progress of labor, and who agrees with the initiation of labor anesthesia, and is readily available to supervise the labor and manage any obstetric complications that may arise. Well, in some institutions, there may be a nurse midwife who is managing labor by herself and has a physician or an obstetrician as a backup, and this individual may not have all this detail. And what this says is that that individual, that backup individual, has to know all these things and has to give approval that an epidural can be placed and has to be readily available. The same thing will apply to family physicians who are managing a patient in labor but doesn't have operative or cesarean delivery privileges. Guideline 4 says that we have to have an IV in every patient who gets an epidural or a spinal. 5 says that vital signs and fetal heart rate have to be monitored on a regular basis. And this also is in red, and again, because I don't think that I can tell you in my experience, and even recent experience, this is not always done. But if an epidural is being dosed for a surgical procedure, where we give a larger volume and a higher concentration of the local anesthetic to provide everything necessary for a surgical procedure, including muscle relaxation, then all the monitors that apply to any other anesthetic, which I mentioned, has to be applied in this case as well. And I can tell you that frequently, again, in my experience, has not been done. Uh-oh. Okay. All right, here we go. Guideline 8 says that an obstetrician has to be readily available to manage any complications that might occur in the process of administering the anesthetic. Guideline 9 says that all these patients have to go to a recovery room that cares for the patient in the same way they would care for any other operative patient. I think in the greatest majority of hospitals, except maybe small rural hospitals, the operating rooms for cesarean deliveries and other operative obstetrical procedures are on the labor and delivery floor, and so is the recovery room. And sometimes the standards that apply to the recovery rooms in labor and delivery do not equal the standards that are used in, say, in the main operating room where someone might be getting a hysterectomy. And then guideline 10 basically says that you have to have a physician in the hospital during the recovery period who can manage resuscitative efforts or CPR. All right, moving on to the ASA closed claims report. Now, the closed claims database is a very large database for adverse anesthetic outcomes that are reported by that have been reported by participating professional liability insurance carriers. Currently, there are about 35 of these carriers who report to the ASA. When a claim is finally adjudicated, then the file is reviewed by an anesthesiologist on the panel. Hospital and medical records are reviewed. Narrative statements of healthcare personnel are reviewed. Peer reviews and expert opinions, depositions of plaintiffs and defendants are reviewed. Jury awards, when applicable, are noted. And other data, such as the sequence of events, the nature of the injury, whether or not the standard of care was met, is also included in the report. The severity of injury is scored from 0, no injury, to 9, which is death. And an attempt is made to determine whether or not the care given was standard, substandard, or impossible to judge. Now, the data I'm going to show you here is from a report that was published in the journal Anesthesiology in 2009. and that's the latest report on obstetric anesthesia. Any questions?
Okay, before we begin the question and answer segment, could all the attendees please type the passcode into the Q&A? Our first question is, in an ER situation, for example, a C-section, what is the proper type of anesthesia to provide the patient?
That's interesting. I'm not aware that there is, most of the time that, in my experience, has been that these patients are brought directly to labor and delivery to an operating room. If something is happening in the emergency room, I think most commonly this is someone who is suffering from massive hemorrhage or a cardiovascular arrest. If the patient has had a cardiovascular arrest, then then after 5 minutes of attempting to resuscitate the patient, then the baby should be delivered. If it is deemed necessary to administer anesthesia in the recovery room, it's probably going to. In the emergency room, it's probably going to be a general anesthetic, and I would use a drug with like ketamine. If we have time, I can explain to you why. But it's probably going to be some type of a general anesthetic. Any other question?
Okay, and can you define readily available for a physician?
No, and I think it's vague for a very specific reason. Readily available has been explained to me as a term that is defined by the institution and the practices in the community. But I'm not aware of any specific term of readily available. It might mean anywhere from being within 10 minutes of the hospital to being in the building but not on the labor and delivery unit.
Okay, and are the ASA standards and guidelines the only standards that apply?
No, these are basic standards. There are other standards that apply, and they're broad and extensive. They're usually determined by common practices. They are often determined by evidence-based medicine. While I would state that no textbook is authoritative because medicine is an art as well as a science, textbooks usually have the weight and force of setting standards, but that's not always true. Standards can include techniques that are used under certain circumstances, the amount of drug that is given, the way to respond to complications, such as the ASA difficult airway algorithm.
Okay, our next question is, how do you define a general anesthetic? What does that consist of, and how is it administered?
A general anesthetic is a state where the patient does not move or respond to a surgical stimulus. It also involves situations where the patient's breathing has to be controlled. It can be administered in two different ways, basically. One is by having the patient breathe a high concentration of gas. We use this for children oftentimes to avoid them the pain and the fear and the trauma of starting an intravenous line first. And then the other way of administering a general anesthetic is through a previously established IV. There have been times when anesthesia has been administered with medication, general anesthesia with medication given by intramuscular injection, but these are usually special circumstances.
Okay, and does a high block occur as a result of the physician piercing the spinal cavity?
Yes, it can. What happens is if an epidural needle or epidural catheter is in the spinal sac or the spinal cavity, then the operator doesn't know that, then they're dosing up dosing up what they think is an epidural, but is really a spinal. And so a very large volume, a large dose of anesthetic can be given. There are ways of testing for this. if a spinal anesthetic is given and the dose is not is either miscalculated or more than than they think is being given, you can get a high block that way as well. There are other ways of getting a high block, such as an attempted epidural that doesn't work, and then someone decides to move on to a spinal anesthetic for surgery. And what happens is the volume of local anesthetic in the epidural space actually decreases the volume in the spinal sac, and so the local anesthetic that is used for the spinal has to be reduced. You can, or at least anticipate that you might get a high block, and position a patient in such a manner that that decreases the likelihood, and be ready to deal with that problem should it arise. So be on your toes with that.
Could you elaborate on the indications of the use of ketamine versus other available anesthetic agents in C-section deliveries?
Yes, ketamine is a great drug. It does have some drawbacks. It's a dissociative anesthetic, and to be honest with you, I never really understood what they meant by that. But the reason it's a good drug is that unless it's given in very high doses, it maintains the airway reflexes. The patient will still be able, even though the patient is quote out unquote, the patient will still be able to cough up anything that might get into the windpipe. It is a very good analgesic. It's a very good pain relief, and it's an excellent amnestic. So patients won't remember what happened. Its drawback is that it can cause difficulty with emergence, where the patient has very unpleasant dreams and hallucinations. And the other problem is that it can cause high blood pressure. Now, this is not a problem in most patients, but if a patient has pre-existing high blood pressure, then it can aggravate it to dangerous levels. Another indication for ketamine is that it can be effective and given as an intramuscular injection. Another good aspect of ketamine is that it will raise blood pressure. So if you are inducing a general anesthetic for a woman who is hemorrhaging, then ketamine will help better maintain the pulse and blood pressure in that circumstance.
Okay, those are all the questions that we have for now, so please continue with the presentation.
All right, thank you. All right. Now, this report compared aspects of anesthesia claims both before and after 1990. In a minute, I'll tell you why I think 1990 was chosen. But if you look at this graph, you will see that after 1990, compared to before 1990, the claims for maternal death decreased. The claims for newborn death and brain injury decreased. There was a decrease in proportion of claims for substandard care, and there was a decrease in the proportion of payments to the plaintiff, 42% versus 58%. The one thing that increased were claims for maternal nerve injury, and there's a good explanation for that. During sometime between 1988 and the early 90s, there was a large increase in the use of regional anesthesia, epidural and spinal, for cesarean sections and other forms of operative procedures in the pregnant patient. I think it was perceived during this time that regional anesthesia was safer. And an early study that was actually published in 1998 demonstrated that a general anesthetic was associated with a 16-fold greater incidence in anesthesia-related maternal deaths than regional anesthesia. And so that perception preceded the data, and I think people were moving more and more into regional anesthesia around 1990. Among the maternal deaths that did occur from general anesthesia in the 1998 study for cesarean sections were primarily airway problems and aspiration. I should note, however, that of all anesthetic claims over the past, I'd say 30 years, only 12% involved obstetric anesthesia. However, the payments or the damages in obstetric anesthesia tended to be higher than other areas of anesthesia, and this is probably a result of claims for neonatal brain injury, which can lead to pretty high damages. All right. Now, if we're looking just after 1990, you can see that even when an anesthesiologist was named as a defendant, the reviewers thought the anesthesia actually made a contribution of about 22% of cases. When it was determined that in newborn death or brain damage, when it was determined that that anesthesia did make a contribution, the three major areas were anesthesia delay and poor communication, and of course they're interrelated, and then substandard care, in comparison to cases where the anesthesiologist was named, but the reviewers didn't think that there was an anesthesia contribution. Now, with respect to maternal nerve injury, the frequency of claims came from nerve root or spinal cord injury. A nerve root is the first nerve that comes off of the spinal cord as it exits the bony spinal canal. And then it splits up into smaller and smaller nerves. So if you injure the nerve root, then a greater area of the body is going to be affected. Obviously, a spinal cord injury it can be as bad as affecting the lower half of the body, including paralysis. When it came to maternal death or brain damage, the three areas that had contributed were primarily high neuraxial block and difficult intubation. Obviously, the high neuraxial block tended to center around regional anesthesia, the difficult intubation around general anesthesia. When the anesthesiologist was considered to have made a contribution to claims regarding maternal hemorrhage, it usually was a result of either being unable to keep up with the bleeding or administering improper blood and blood products. All right. Now let's look at some cases that I had been involved in that I hope will highlight some of the issues that I had just mentioned. The first case deals with a poor neonatal outcome. The obstetrician and the obstetric team failed to recognize fetal bradycardia, which is a low fetal heart rate. The infant was delivered with ischemic encephalopathy or brain damage, and the anesthesiologist was named as a defendant along with the obstetric team. I was asked to opine as an expert witness for the defense, and I concluded that the anesthesiologist was either not liable or, at the least, very limited in his liability. So here's what happened. Patient was in labor with an epidural, was functioning well. There was an attempted forceps delivery by the obstetrician that was unsuccessful. So a C-section for failure to progress was ordered by the obstetrician, and he left the area. This was considered to be urgent, but not an emergent situation. Shortly following the dosing of the epidural for a surgical procedure, the external monitors were removed by the obstetric team, the nurses, so that they can prepare the patient for a surgical procedure. It took approximately 30 minutes from the time that they took off the monitors to the time that the baby was actually delivered, and we ended up with a very severely depressed baby. So I was asked to opine as to what was the anesthesiologist's duty to the fetus, and I believed that it was limited only by the effects that the anesthetic had on the fetus. Usually this is through the mother, and either her blood pressure drops or the uterus becomes tetanic or just tightens up so tight that the placenta can't transfer oxygen and other nutrients to the baby. The anesthesiologist can intervene by correcting the mother's blood pressure, giving drugs to relax the uterus, but that's about it. The anesthesiologist does not have that skill or knowledge, nor does he or she have privileges to perform an operative vaginal delivery or cesarean delivery. Now, this was a case, I think, of poor communication. The anesthesiologist during deposition testified that he saw the fetal heart rate drop just prior to removal of the monitor, but he didn't say anything. I think he assumed that the low heart rate was also noted by the obstetric team, and apparently they didn't think it was, he thought they didn't think it was very concerning. So the question, of course, is who's responsible? Is the obstetric team or the anesthesiologist or both? I believe that the primary responsibility was the obstetric team because these are the people who know electronic fetal monitoring in detail, and they are constantly observing the fetal heart rate monitor throughout the patient's labor and delivery. Nevertheless, I think that the anesthesiologist's testimony did create some difficulties for him. The next case is one that involves maternal death, and this one highlights substandard care. This was a case where both the obstetrician and the nurse anesthetist were named, and I opined, again as the expert for the defense, that the obstetrician was not responsible for the actions of the nurse anesthetist. In this rural hospital, there were no anesthesiologists on staff. The patient was scheduled for a C-section for failure to progress. The nurse anesthetist attempted a spinal anesthetic, but it failed. So the next step was a general anesthetic, and I had no problem with that. That's an appropriate plan B. But what happened is that the nurse anesthetist failed to recognize that the trachea was not intubated. He told the obstetrician to start. It was only after the operation was underway that he found out that something was wrong. He attempted to resuscitate the mother. He did not do so skillfully as expected of a nurse anesthetist, in my opinion. The baby lived, but the mother died. So I was asked to be an expert witness for the obstetrician. In my analysis, the obstetrician did not practice below the standard of care for an obstetrician. The obstetrician's primary responsibility is to the surgical care of the patient. This was strictly an anesthetic mishap, and so it was an anesthetic issue and therefore not an obstetric issue. And my reasoning was that the obstetrician does not have, nor should he or she have the required knowledge or skill of a nurse anesthetist. The obstetrician or any surgeon must rely on the knowledge and skill of the nurse anesthetist. The obstetrician does not have, nor should he or she have, the knowledge or skill to resuscitate the patient or save the patient from an airway or anesthetic complication, certainly without putting the patient at risk from hemorrhaging. But I was posed with a legal question at trial and to interpret a statute. And the statute basically said, and I don't know it in detail, but it basically said in this jurisdiction that the nurse anesthetist and the surgeon are interdependent to each other. And the way I interpreted that was that the surgeon, in this case the obstetrician, would provide the nurse anesthetist with medical diagnoses and treatments that may have an impact on the anesthetic plan, and that the nurse anesthetist and that the obstetrician relied on the nurse anesthetist to have the knowledge and skill to administer an anesthetic and handle its complications. I might add that it appeared that the jury agreed with me, but not 100%. And if we have time and you want to discuss it, I'll go into more detail. I thought the result was really quite interesting. All right, now number 3 is another case of maternal death, and this is where I was asked to be an expert witness for the plaintiff. And it was a no-brainer to me that the anesthesiologist involved practice below the standard of care. Here's what happened. The patient called her obstetrician about a week following her cesarean delivery complaining of a headache. Her history included a spinal anesthetic. Her obstetrician recommended that she return to the hospital where she received her care. The patient arrives at the hospital where the anesthesiologists are instructed to treat her spinal headache. Spinal headache occurs when there's a hole in the spinal sac, the fluid leaks out. The treatment for that, or the definitive treatment, is putting an epidural needle in the epidural space, drawing some blood from the patient sterilely, and injecting that through the epidural needle. It seals the hole, and the patient's headache goes away almost immediately. Very dramatic improvement. So what they did is they attempted an epidural blood patch, but the patient couldn't tolerate it, so she didn't get it, and she was sent home. The next morning, her husband finds her dead in bed. An autopsy was performed, and the neuropathologist noted severe cerebral edema or swelling of the brain, which he presumed to be due to severe hypertension or high blood pressure. When I reviewed the records, I noticed that the anesthesiologist never took vital signs. Well, I mean, this is clearly below the standard of care. Vital signs are vital, and it's standard to take vital signs before and after a procedure. In addition to that, there was poor communication. There was a diagnosis of spinal headache, and this was assumed because, of course, she had a spinal anesthetic, so therefore her headache must be a spinal headache, right? Well, no one ever formally evaluated her for other causes of headache, and there are some causes of post-delivery headache that can mimic a spinal headache, but they can be very, very serious. So what happened was, it's sort of like playing the game of telephone. I mean, something comes down the line, and nobody questions what had been given to them from before. So a misdiagnosis was perpetuated. I call this a fixed diagnosis, where other possible causes are apparently not considered or never were considered. So I think the lessons here were that the anesthesiologist, or really any physician, should always confirm the diagnosis for himself or herself. And you just don't cut corners unless there's a very defensible reason to do so, and it should be documented. All right, moving on to other potential areas of liability. Sometimes these usually occur when there's overlapping responsibility or turf battles. Whenever there is a sudden change in fetal condition, it's not uncommon for everyone on the obstetric team to focus on getting the patient to the operating room without realizing that the anesthesiologist needs to get to the head of the bed to care for the patient. And this includes dosing an existing well-functioning epidural catheter with a rapidly acting local anesthetic. So this avoids the need for general anesthesia. But of course, everybody becomes very concerned about the baby, and the obstetrician might insist on a general anesthetic anyway, because he or she believes that that is the fastest way to get the baby delivered without giving much regard to what is the safest for the mother. Blood transfusions can be an area of contention. The surgeon may order blood when the anesthesiologist deems it not necessary. If the anesthesiologist administers the blood anyway under the pressure from the surgeon, and then there's then a complication from the blood transfusion, and who becomes responsible? I don't think an anesthesiologist is going to be able to get away with this completely, because he or she still participates in that process. If another area is pre-delivery consultation, if a patient has a disease or condition that may have a significant effect on the patient's anesthesia, such as heart, lung, or nervous system disease, then the best time for the anesthesiologist to become aware of this is before the patient goes in labor, and the patient should see the anesthesiologist in consultation before she arrives. And unless there is a program at an institution where every patient who's going to deliver goes through a sort of a pre-screening process by the anesthesiologist is totally dependent on the obstetrician. The obstetrician doesn't send it to the anesthesiologist, and the anesthesiologist sees these problems for the first time when the patient comes in labor, and that might be a little late. The next area is a sensitive political one for me, I believe. I think it is for everybody. The organizational bodies of nurse anesthetists and anesthesiologists have at times in the past, and perhaps currently, been at odds with each other, where there's contention over the issue of who is qualified to administer anesthesia independently. The AANA, which is the American Association of Nurse Anesthetists, has taken the position in the past that nurse anesthetists can function independently without anesthesiologist supervision or direction. The ASA, of course, believes that anesthesia is the practice of medicine and that anesthesiologists should supervise or direct non-physician anesthesia providers. Unfortunately, this doesn't happen too often, but unfortunately it does. These conflicts manage to make their way into the operating room. So number one, every department really should clarify when the anesthesiologist should be notified of critical events when he or she is not in the operating room and it's just a nurse anesthetist. In addition to that, this is even rare, fortunately, nurse anesthetists will sometimes bristle at the direction of that the anesthesiologist may give and may even go as far as being unwilling to give up control even in a crisis. That happened to me once. It was very upsetting to me. The patient made it fine, by the way. All right, future areas of liability. I think a hot topic right now is something called team management. It's also called crisis management, and the aspects of this kind of management is that it's organized, and it's organized in advance of anticipated or even unanticipated crises. An identifiable team leader is present, and that individual maintains that leadership until he or she transfers it clearly to someone else. Everybody else on the team has an identifiable role or duty. There has to be clear communication, which means that the person receiving a request lets the requester know that it has been heard and has been heard accurately. There must be situational awareness where where these individuals are not only focused on what they have to do, but they're aware of what's going on around them so that if they can relieve themselves of their responsibility, they can offer help to someone else who is having trouble fulfilling their duties. There's also a concept of all hands on deck, and what that means is that everyone who's available, everyone who's not taking care of a patient who is in a critical state, such as a nurse taking care of patients who have already delivered and they're all stable, that they are required to come on the scene and offer whatever help is necessary, and they don't leave until they're given permission to do so. There also should be crisis management protocols, both for common and uncommon situations. I know that one of the focus in obstetric units is obstetrical hemorrhage, and protocols are being developed. They're often fine-tuned to the institution itself. And I think that regulatory bodies are going to insist that hospitals maintain mock drills, not only in labor and delivery but elsewhere, and utilize high-fidelity simulation. We have computerized patients now that can come pretty darn close to an actual situation, and you can manipulate the situation to throw, if you want, to throw the team members off and see how they respond to a sudden, unexpected change. So, in summary, like all other medical specialties, anesthesiology is complex. Unfortunately, I have come to realize that both other physicians and even nurses think that anesthesia is so easy, a caveman can do it. All you do, by the way, is just push a drug and then just let the patient wake up, which obviously is not true. The majority of the liability in anesthesia, in OB, lies with communication, timing, and skills. There are conflicting interests in patient care, both among physicians and nurses, and these conflicts, if they are not resolved quickly, can lead to poor patient care and poor outcomes. And I think in the future, crisis management and team management and simulation are likely to become standards in, I guess, institutional practices. I see this within the next decade. And then finally, I'll just put this up. These are the two reference texts in anesthesia. One, Miller's anesthesia covers all of anesthesia. It's probably the most popular. Chestnut's obstetric anesthesia is also, I think, the most widely used in obstetric anesthesia circles. Are there any more questions?
Could all the attendees please type the passcode into the Q&A once again? And our first question is, can you briefly discuss how a physician or CRNA can ensure proper ETT tube placement? How can they be sure that the patient is intubated properly?
Yes. While there are many ways to place an endotracheal tube in difficult situations, the sine qua non, if you will, is that we get we measure carbon dioxide in the expired gases. That carbon dioxide is not just a couple of blips and goes away. It's there continually. I hope that answers your question.
Can you briefly discuss some common contraindications to the use of epidural or spinal anesthesia during vaginal delivery, and what % of patients do you find require some form of anesthesia during childbirth?
The contraindications to epidural anesthesia is for labor are really quite few. Patients who have a systemic infection that hasn't been treated is considered, a relative contraindication. A patient who is hemodynamically unstable, she's bleeding, or for some other reason has very low blood pressures, because the epidural will make that worse, and an infection at the site of placement of the epidural are the three absolute contraindications that I can think of at the moment. In our institution, or where I've practiced the most recently, approximately 80 to 90% of patients get epidurals. Of those who don't, I would say probably 50% or more get some kind of systemic analgesic, such as a narcotic sometime during labor. Now, nationally, it might range anywhere from 50% don't get anything, they don't want anything, to and the rest split between narcotic injections and epidural labor analgesia. Anything else?
Okay, this will be our last question. Can you speak to the incidence of being a level off during administration of spinal anesthesia and the consequences thereof?
I'm sorry, can you repeat that again?
Sure. Can you speak to the incidence of being a level off during administration of spinal anesthesia and the consequences thereof?
I would say that for patients there's data to show that patients who are range in height, I think I'm answering your question, from 5 feet to 6 feet, will get the same level of anesthesia from a dose of, say, bupivacaine, and it's 12 milligrams, 12.5 milligrams, and it's hyperbaric, meaning it's more dense than the spinal fluid, and so you can kind of control how high it gets based on how you position the patient. Now, I'd say that most of the time, that's 90% of the time, in these instances, whether 5 feet to 6 feet, and there's nothing else to alter the dosage, just the height, that we are off by one level, maybe only one level, maybe, and no more than that, maybe 90% of the time. Did I answer your question?
Okay, and we will continue.
I want to know if I answered.
Oh, yes.
I'm sorry?
Yes, you did.
Okay, good. All right. I will.
And
if
this
anybody
webinar
else
is eligible. Thank you for answering those questions. And for the CLE information, this webinar is eligible for CLE credit in California, Illinois, Minnesota, Missouri, New Jersey, Pennsylvania, and Texas. To ensure that you receive your CLE credit, please complete the survey at the end of the presentation. This is a reminder that CLE certificates will be provided within 24 to 48 hours via email. In addition to being your best source for testifying and consulting experts, TASA also offers e-discovery and document management solutions, free interactive webinars, and research reports on expert witnesses such as the Challenge History Report 2.0, the Professional Sanction Search, and the Expert Profile 360. I want to take this opportunity to thank everyone for attending, and most especially Dr. Stephen Fogel for his time and effort in creating this presentation. If you would like to speak with Dr. Fogel, or if you would like to speak with a TASA representative regarding an expert witness for a case that you are working on, please contact TASA at 1-800-523-2319. This is a reminder that we'll be sending out a link to you tomorrow with the archive recording. This email will also include our upcoming invitations to our webinars, such as a stormwater management webinar and a How Hackers Attack webinar. The archive recording will also be posted in the Knowledge Center on TASA's website. If you have any questions or comments, please email Carol Kowaleski. Thank you all again, and have a great day.